Okay, so what we're going to do is talk first about a problem that we're trying to address with our research, and that is the average modest effects of what we do. Then discuss potential solutions, and then talk about two studies where we've looked at one way to solve this problem. And we want to do it by understanding not only are the treatments that we provide effective, but we want to understand why are they effective, and most importantly, perhaps, for whom they're effective. The idea being that as we understand more and more about the mechanisms underlying what we do and the people that respond most, we'll be able to identify those patients for whom different treatments are most effective, precision medicine. And then I'll be talking about the clinical and research implications of our findings. So, the problem. In pain treatments overall, not just psychological treatments, but pain treatments, we just get modest effects on average. And all of us, who treats pain? Nearly everybody. Who uses cognitive therapy in their treatments? Some. Who uses hypnosis? Some. Who teaches mindfulness? More. So we got cognitive therapy, mindfulness, and hypnosis. My hope is that after this talk, you will learn to do all three. That's my hope. So, but anyway, getting back, that many treatments exist. And many of them, including these three we talked about, are proven to be effective on average. But the effects on average are modest. We've all seen patients that we treated whose lives are changed with our treatments. They get huge benefits, and we've seen patients that get little benefits. So we see this range. On average, it's modest. But these treatments are rarely compared head to head. And when they are, they usually get about the same effects. And so when we see that, one urge is to develop new treatments. And so we see new treatments come along all the time, and guess what? They have modest effects. Another solution is to identify the patients that might benefit from each one differently, and then assign patients to the treatments they're most effective for. And to do that, we need to understand the mechanisms underlying the treatments and for whom they're most effective. So that's what our research program is now focused on. And I'm going to present the results of two studies, randomized clinical trials that are looking at this. And the three questions I'm going to address is, do they work? Why do they work? And for whom they work? Those are the analyses I'm going to present. The first study compared 4 sessions of individual therapy comparing cognitive restructuring. Most people do that here. A self-hypnosis, fewer do that, but some of you do that. But this was self-hypnosis focused on pain reduction, using hypnosis to decrease pain. The second hypnotic intervention was using hypnosis to change thoughts about pain. So the suggestions were targeting thoughts. And then the control condition was just teaching people how pain works, pain education. The second trial compared 8 sessions of group therapy, teaching people mindfulness meditation, or teaching people self-hypnosis, both to reduce pain and to change their thoughts, and again, a pain education condition. And the primary outcome in the study was average pain intensity, but we also looked at others, including depression. And the questions, again, were these treatments effective, about efficacy? And if so, how were they effective and for whom? And this is what mechanism research is about, is to identify the moderators, mediators, and predictors of treatments. And so you think about, well, what would be the potential mechanisms by which psychological treatments would work? And we use this model to identify how psychological interventions work. And our model is that all psychological treatments come down to basically these few things. First, they change or can change behavior, what people do. And operant treatment, behavioral treatment, focuses on just changing patient behavior. The idea being that once people change what they do, their thoughts and feelings and processes will change along with it. The second thing that these things can do, mechanism, is the content of people's thoughts, what they think, negative thoughts or positive thoughts. and cognitive behavioral therapy, which is the treatment most people in this room are using, do that. They target thoughts. A third potential mediator is cognitive processes, or how people think. And it's not so much what people are thinking, but how they relate to those thoughts. And the treatment that focuses on this, of course, is mindfulness, teaching people to have a different relationship, a more positive relationship with their thoughts. Also, some treatments focus on emotions and affect, anxiety, depression, and anger. and the idea being that when you change people's emotional responses, the other things can fall suit. And a relatively new treatment that's come along, emotional awareness and expression therapy, a very interesting treatment, and we're just starting to test that in a new R01 that was been awarded and compare it to others. So that focuses on this. So as a therapist, you can see, what things should I focus on to change somebody? I'm interested in brain states as something that either we change with our treatments or that predict how people respond. And I'm also interested in environmental factors, how they're in the family. So all these treatments, you can take the hundreds of pain treatments or depression treatments or anxiety treatments, and they will target one of these things in this model. So we wanted to study mediators from all of these categories. For cognitive content, we looked at beliefs about the body, beliefs how disabled people are. For cognitive processes, we looked at cognitive self-statements and ignoring pain. Emotional responding, in the first study, we looked at depression. And this idea of catastrophizing, it's a combination of cognitive content and how people think. And behavior, we looked at how engaged the patients were with the treatment. And brain state. We also looked at the power of different brain oscillations. We'll talk about that in a little bit more in detail. And then environment, that is the therapeutic alliance. The second study looked at these same categories. Many of the mediators we looked at in the two studies were overlapping, but the second study also looked at different ones. So the overlapping ones are listed here. But we looked at basically many mediators. And for moderators, we used the limit, activate, and enhance model to identify potential moderators of treatment. And the idea being that all psychological treatments, again, do some combination of teaching people to limit something that they're doing that's bad, or teaching them to activate something that they're not doing that they should be doing, or taking advantage of some basic trait or skill. So people who have an excess of catastrophizing, maladaptive thoughts, we want to teach people strategies to limit those, to reduce this bad stuff. People who are not doing helpful things, we want to activate them. So we want to teach people to exercise more or to activate appropriate coping responses. And then people who have signature strengths, so maybe more baseline mindfulness, able to use mindfulness, or baseline hypnotizability, able to use hypnosis. We want to match them to treatments that take advantage of, so that those basic personality traits or basic traits can enhance outcome. So in these studies, we looked at these potential moderators. We looked at catastrophizing as a baseline moderator, that is, thinking people who are high in catastrophizing at baseline may do better with those treatments that decrease or target catastrophizing. We wanted to, for enhanced variables, we thought baseline hypnotizability might predict response to hypnotic treatments. We also have evidence that certain brain oscillations predict response to different treatments. So we predicted that having more alpha power, and again, I'll talk about what that is in a little bit, people who respond more to hypnosis, who have more alpha and theta, these slow wave activities. And then we also wanted to look at different brain activities as exploratory analyses. Again, in study 2, very similar set of potential moderators with many overlapping. So the treatments that we examined in more detail, again, Most people here use cognitive therapy, so you know that it involves teaching people to monitor their thoughts, talking with them about how adaptive or not adaptive those thoughts are, and teaching them to come up with new thoughts that are more adaptive, and giving people homework to practice this at home. And this was looked at in only the first study. Hypnosis focusing on pain reduction. We did a classic relaxation in favorite place induction, the idea being that this encourages people to be more open to ideas, and then we gave hypnotic suggestions for pain reduction, focusing on pain reduction. Home practice was listening to the audio recordings of the sessions and practicing self-hypnosis without the recordings, and this was only looked at in the first study. Hypnotic cognitive therapy is similar. You teach people, like in cognitive therapy, to monitor their thoughts, evaluate them, but instead of using logic to come up with useful thoughts, use hypnosis. So basically encourage people to let hopeful thoughts sink into their unconscious and become automatic. So getting at this hypnotically versus logically. And then home practice, again, listen to the recordings and practice self-hypnosis on their own without the recordings. Pain education was basically our control condition. We taught people how pain worked, and for home practice, had them listen to the recordings that summarize the information, and this controls for time and attention. But we also now have evidence that teaching people how pain works, how the brain and body create pain, is actually an active treatment. People are more reassured when they learn that pain is created by the brain. It's not created by the body. The brain creates the experience of pain to warn us, so it doesn't mean damage is happening necessarily. It just means watch out. And when people understand that, really understand that, their pain levels go down. Interesting. Mindfulness, many people in this room teach mindfulness. You know it's training people to focus their attention on certain objects and certain experiences, acknowledge them, but don't necessarily join with them, let them go. And we had a series of sessions for them to listen to at home as well. This was examined in study 2 only. And then in the second study, we had this combination of teaching people self-hypnosis to decrease their pain and change their thoughts. So those were the different treatments we examined. First set of analyses were about efficacy. Did we see a change in pain or depression with these treatments? And the answer is yes. Average pain decreased, varied from around 0.7 to 1.4 on a 0 to 10 scale. Typical for this, moderate effects. In study 1, the effects for cognitive therapy, changing thoughts, and hypnotic cognitive therapy, changing thoughts with hypnosis, were significantly better than the control condition. And we didn't have a no treatment control condition in this study, so I pulled data from another study that asked the question, what happens to pain when you do nothing? And it's significantly less. So all 4 treatments yielded significant effects, significant reductions in pain. On depression, similar outcomes, except for that there was no significant between group difference. There was significant reductions in depression for all 4 treatment groups, and when you do nothing, you don't see much change. So the treatment for depression were effective. And for the second group, which was group therapy, we also saw significant reductions in pain, but less than individual therapy. And for depression, similarly, significant reductions in pain, and again, less than the individual therapy. So all interventions were associated with significant reductions in pain and depression. But there were few between group differences. The only one that really emerged was in the first study, and that was that the treatments focusing on changing thoughts were the ones that had the most effect for changing pain intensity. Individual therapy was more effective than group therapy, and the effects of these treatments for pain intensity were larger than for depression. But all treatments worked, on average, modest effects. Now we get to what I think are the more interesting analyses, which is mediation. Why did treatment work? And again, we looked at a whole series, a whole bunch of different possible mediators based on our theoretical model. And in study 1, about half of the mediators changed significantly with treatment. So a full half of the ones we potentially thought might explain outcome did not change. The 8 that changed were 3 beliefs, 2 cognitive processes, depression as an emotion, and catastrophizing. And we also looked at engagement in treatment with treatment, and days listened to recording were significantly different across the groups, as was therapeutic alliance. Similarly, in study 2, about half the things we thought explained treatment changed. So a fair number, but not all of them. Which of these were associated with change in pain intensity? Again, half again, so roughly 20 to 25% overall. Changing beliefs in the control about pain, changing depression, changing catastrophizing, and therapeutic alliance all predicted outcome, but none of the others, just those 4 in the first study. The second study that was fewer still, a willingness to experience pain was associated with an improvement in pain, changes in catastrophizing, and therapeutic alliance. Across the 2 studies, catastrophizing and therapeutic alliance emerged as the things most closely linked to outcome. Now, the next step is to do an official mediation analysis to see how these might change as a function of treatment condition. So maybe there are some mechanisms that are unique to certain conditions, and in one, only one emerged, and that was this. Changes in control beliefs, my sense that I can control pain, were associated with outcome in the 2 groups that focused on changing thoughts. So changing thoughts was a specific mediator for the groups that focused on changing thoughts. It makes sense. And it was control beliefs that emerged. For the second study, 2 mediators emerged. One was catastrophizing, and that was, catastrophizing was specific to mindfulness meditation. So mindfulness meditation, when you do it, how it works is related to your ability to change catastrophizing thoughts. And therapeutic alliance was important. That mediated the effects of hypnosis. So therapeutic alliance is particularly important when you're doing hypnosis. To summarize all this in terms of mediation, about half of the hypothesized mediators improved with the intervention. Half did not. And in order to explain outcome, it must be affected by treatment. So half are just, we could remove as potential mediators. And less than half of those were actually associated with outcome. So these treatments only work through a few mediators, not a lot. And the ones that seemed most important are catastrophizing thoughts and therapeutic alliance. That was consistent across both groups. So when you're doing treatment, if your patient is catastrophizing, get at it. And develop your alliance with the patient. Those are the 2 key things here. Pain control beliefs were important for the cognitive therapies. Depression was important, pain willingness. So these are things that we need to look at more carefully, but not as important as catastrophizing and therapeutic alliance. And again, we want to maintain our focus on catastrophizing as something that's going to help our patients, and we need to consider therapeutic alliance more. Really work to build and maintain that. We're taught that when we learn therapy, but sometimes we forget it. That everything we can do to build and enhance trust and alliance is critical in therapy. And again, more research is needed. Of course, more research is always needed because I need a job. But it also is important to understand these things. And again, especially pain control beliefs may be important when you're doing cognitive therapy. Understand how well your patients are doing in terms of their beliefs about control over pain and enhance that, and you should be able to enhance outcome. So who responded to these treatments? Does everybody respond the same, or are there individuals that respond more to one treatment than another? And we tested baseline catastrophizing, thinking that those who are high in baseline catastrophizing might respond more to cognitive therapy. And we thought that hypnotizability might predict response to the hypnosis treatments more than the other ones. We thought that alpha power and theta power, the slow wave activity, I'm going to talk again about it in a little bit more so you get a better understanding of that, would predict response to hypnosis. And we wanted to look at other different brain activity measures as potential predictors of outcome. Study 2, we had similar but different ones. Because study 2 included a mindfulness condition, we also thought baseline mindfulness might predict outcome. That is, people who are generally more mindful in their life might really take a shining to and respond better to mindfulness more than the others. That was our hypothesis, which was wrong, by the way. We'll get to that. And then we explored some other things. So what emerged? At a p of less than 0.033 value, delta power, alpha power, and gamma power, brain activity predicted outcome. And then hypnotizability predicted outcome for depression. And for study 2, pain intensity, the non-reactivity mindfulness and observed mindfulness. So in fact, mindfulness did predict outcome, but it was for hypnosis, for two mindfulness domains and mindfulness for the other. And alpha and delta power at baseline predicted depression. So to understand how these factors are related to outcome, we look at the slope. And this is an example of a slope that we look at. We are interested in these lines. And this line tells us who responds better to which treatment. And so in terms of response, we're looking at the y-axis, change in outcome, with lower being better. That's a reduction, in this case, in depressive symptoms. And the error bars around that indicate where the significant effects are. So when these error bars don't overlap with 0, those are the people that respond best to the treatment. So in this case, we're looking at hypnosis focused on pain reduction and hypnotic cognitive therapy, and we found that baseline hypnotizability predicted response, consistent with the idea. That is, people who are higher in hypnotizability at baseline respond better to hypnosis focused on pain reduction and hypnotic cognitive therapy. If you have a hypnotizability score of 4 or 5, this is a good treatment for you for reducing depression. Less than that, maybe, maybe not. But you're really going to respond most if you're in higher hypnotizability. People lower, they don't do as well. Some do well, some do not so well, but it's people that are highs that really seem to respond more to that. So high hypnotizability may facilitate the benefits of self-hypnosis training. That's what we found. What about mindfulness? Again, we expected that people who are higher in mindfulness might do better with mindfulness treatment. We found that, in fact, people low in non-reactivity did better with hypnosis. So people who started out low in mindfulness actually responded more to hypnosis focused on pain reduction. And people higher didn't do so well. So the people that have lower skills or lower practice may actually learn something. Instead of being an enhance variable, something that we build on, it might be an activate variable. People who aren't using mindfulness may really benefit from these treatments. And similar outcomes with respect to hypnosis and mindfulness treatments. Those who are lower responded better. That's where the error bars are less than 0. People higher didn't do so well. Baseline mindfulness seems to predict response to both hypnosis and mindfulness training. So low mindfulness may facilitate this. Okay, now I've talked to you about bandwidth power and EEG. I'm going to go a little more details to help understand the findings. So to measure EEG, which is basically measuring the activity of billions of neurons at the surface of the skull, how active they are. And you measure that with electrodes over the skull, and you get the signal of all these neurons firing. But you can slice it up into different wavelengths. And delta is this very slow wavelength, 0 to 4 hertz. And when somebody has a lot of delta, they're sleeping, deep sleep. Somebody with a lot of theta, neurons firing in groups 4 to 8 hertz, they're either drowsy, or if they're awake, they're very focused. This wavelength is associated with focused activity. And alpha, in neurons firing 8 to 12 hertz, the brain is relaxed. Alpha neurons release neurotransmitters that quiet the brain. So paradoxically, when there's more alpha, the brain is more relaxed. Alpha is like a librarian walking around going, shh, shh, everybody quiet now. So there's more librarians, there's more quiet in the room. And beta and gamma, these fast activities, that's associated with processing, thinking. And what we were interested in was this idea that because hypnosis is associated with this focused attention, maybe people who are awake and have more theta might respond more to hypnosis. We thought maybe alpha might be associated with mindfulness because it's a brain that's quiet. And so we'll see. What emerged was that delta power predicted response to hypnosis focused on pain reduction. So people who had low delta, they responded better to hypnosis. People with high delta responded less. And remember what delta was. So delta is this wavelength associated with deep sleep. So a brain that's kind of asleep doesn't do so well with hypnosis. The brain has to be at least somewhat active to be able to follow the suggestions, apparently. Again, this had a very similar effect on depression. People low were more able to respond to hypnosis than people at high. So this delta power may reflect processes that interfere with hypnosis. So if you didn't get a very good night's sleep last night and you're kind of sleeping right now, we shouldn't use hypnosis with you. Your brain's not in a state for hypnosis. And again, looking at what delta is, it's this brain that's kind of asleep. So you want the brains of somebody, if you're going to use hypnosis, to be at least somewhat awake. If somebody is sleeping during hypnosis, probably not going to respond so well. What about alpha? And you remember, alpha is this relaxed brain. Not the monkey brain going on, the brain just relaxed. That predicted response to both hypnosis and cognitive therapy, but in different ways. And this is a completely new finding. No one has ever looked at how brain waves predict response to cognitive therapy. We have some evidence that slower brain waves respond more to hypnosis, but we hadn't looked at cognitive therapy. So, as has been found before, people high in alpha power, it's not been found before. People who have lots of alpha do not do well with cognitive therapy. And these brainwave patterns are traits. They're highly stable. So some of us in this room have alpha brains. Some of us have more beta brains. Some of us have more theta brains. These patterns are unique to individuals. And if your patient is high in alpha, they're not going to do well with cognitive therapy. But they are going to do better with hypnosis. A relaxed brain does better with hypnosis. On the other hand, people who are low in alpha have the opposite pattern. Low alpha does better with cognitive therapy. A brain that is not so relaxed, a brain that's more engaged, does better with cognitive therapy. A brain that is not so relaxed does not do so well with hypnosis. So high alpha power may enhance responses to hypnosis, but interfere with response to cognitive therapy. What about alpha and depression? Again, people high in alpha respond better, report lower pain intensity, more decrease in pain with hypnosis focused on pain. And again, alpha power may enhance response to hypnosis. Thinking about what alpha is, yes, 3 more minutes? Oh, it says 9 minutes here, but 3 more minutes. Okay, we'll finish up. Gamma, people high in gamma don't do so well with hypnosis. A very, very active brain. Too much gamma may interfere. And again, so to summarize then, a fair number of moderators emerged, more than mediators. We can predict response to these different treatments, and the pattern of findings were consistent with hypotheses related to hypnotizability and bandwidth power. More slow wave power, better response hypnosis, more hypnotizability, better response hypnosis, but were inconsistent with mindfulness. It was low mindfulness that predicted better response to hypnosis and mindfulness treatments. Hypnotizability enhanced the effects of hypnosis on depression, and these very slow oscillations and very fast ones interfered with hypnosis. You want the brain to be at the sweet spot to respond to hypnosis. And as I said, alpha oscillations enhance response hypnosis, but not with cognitive therapy. And people high in trait mindfulness do not do so well with mindfulness or hypnosis. So, limitations of the study, just 2 so far. We're starting another one right now. And there was lack of a no treatment control condition, so we don't know what happens to how these brain activities predict response to no treatment. And we did a large number of analyses. We did control for alpha inflation by lowering the p value, but we didn't lower it by a huge amount. Strengths, these were high sampled studies. And in general, the hypotheses were supported, except for with respect to mindfulness. So, in summary, catastrophizing and therapeutic alliance were consistent across all treatments. These are things that we need to focus on. True treatment mediators are rare. They were control beliefs, catastrophizing, and therapeutic alliance. And more moderators emerged and may have emerged if the active control condition was less active. But in the meantime, clinicians may want to focus on those mediators identified. Moderators were easier to identify than mediators. Different brains appear to respond to different psychological treatments. Don't offer the same treatment to everybody. Learn a variety of treatments. And it supports the premise that precision medicine is possible. An active mind may do better with cognitive therapy. A relaxed mind, but not too sleepy, responds better to hypnosis. And someone who does not endorse high levels of mindfulness may do better with mindfulness. So I want to acknowledge funding for this research from multiple sources, and thank you very much for your attention. We have time for questions? Yeah, so it looks like we have time for comments or questions. How much time should I give it?
I was wondering about the control the patients believe they have over their pain.
Yes.
Have you looked at what the therapists believe as their ability to control or help mediate for the patients?
We have not looked at that, the therapist beliefs. In these trials, we train the therapists, so they understand what they're to do in the different conditions, but we never ask them, do you think this, which condition do you like the most? So that'd be a very interesting question, absolutely, yeah. More an environmental question. I know that if you're a therapist who believes in your patient, then they're going to do pretty well. If you don't, yeah. In these studies, no, but we've done 2 studies to look at neurofeedback as a way to enhance hypnotic responding. And when we did those studies, because the research says that it's more consistent with theta, we enhanced theta in the front midline. Theta, yeah. And in both pilot studies, we got a signal. That is, those who learned neurofeedback, the hypnosis stayed longer. It stuck more. Those who did not learn neurofeedback, they got immediate effects that then maintained. Those who got neurofeedback continue to improve. So yes, you can train a brain to be more responsive to hypnosis.
And give feedback to the doctor, to
A patient?
No, give power
to
you as a therapist.
Now that'd be interesting. Yes. So one of the criticisms of this research says that it's interesting that EEG predicts outcome, but who has the money to do full EEGs? But the technology is improving. So pretty soon there'll be an app. You put an electrode on your client's head. You can look at their levels and then go, oh, this person's a good cognitive therapy candidate. Or do a hypnotic induction and go, yep, we're getting an effect here. Oh, they like that induction more than that induction. Yeah, cool.
Question? Here. Here.
Okay.
I'm over here. I was wondering about the therapeutic alliance idea. Isn't it, what exactly it means? Because isn't it about like a chicken and an egg here? If the client is coming not for empathy right now, they're coming for reduction of pain. So you'd think that the alliance is established by your ability to reduce pain, which is what you're exploring in the rest of all the different types of treatments. How does it stand out on its own?
Yeah. So in these studies, we measured therapeutic alliance the first 2 sessions. So how connected did the patient feel to the therapist? I like the therapist. They listen to me. I feel connected to them. And that patient-reported alliance predicted subsequent change. So it's true that if the patient is doing better, then maybe they go, oh, I like my therapist more. But in fact, in this one, it was measured before the outcome. So thanks again for your attention. Oh, and we'll have time after the break.